Welcome to the deep dive. We're here today to really get into pelvic fractures, specifically gearing you up for your MSRA. We've looked through the notes, and the plan is basically to pull out all the essential stuff you need to know, make it clear, make it stick.
Exactly. Pelvic fractures, they're a big topic. They range from, well, relatively stable injuries right through to emergencies that are immediately life-threatening.
Yeah.
Understanding those differences and the key steps in management, that's absolutely vital.
Yeah, there's a lot there. So we're aiming to distill it down into those high-yield points for revision.
That's the goal. Digestible chunks.
Okay, let's dive right in then. When we say pelvic fracture, what exactly are we talking about? What bones?
So fundamentally, it's a break in any of the bones forming that pelvic ring. That's your hip bones, the ilium, sternum, and pubis, and also the sacrum and coccyx at the back. But the really crucial thing to grasp isn't just the bone, it's what's inside the pelvis. Major blood vessels, nerves, organs, they can all be affected.
Right, so it's not just a broken bone, it's the potential for, well, major internal chaos.
Precisely. And that's why we immediately think about severity. You've got high energy trauma, big impacts like car crashes, falls from height. These often cause massive disruption, serious bleeding, life-threatening stuff.
Mm-hmm.
Then on the other end, you have stable fractures, often lower energy, maybe an elderly person falling, perhaps with osteoporosis making the bones weaker. Might just be one bone broken, less immediately critical usually.
Okay, and you mentioned avulsion fractures earlier. How do they fit into this picture?
Ah, yes. Avulsion fractures are a bit different. They're caused by a really sudden, strong muscle pull. Imagine a sprinter, the hamstring contracts so forcefully it actually yanks off a piece of bone where it attaches.
Ouch.
Yeah. But usually these don't mess up the overall stability of the pelvic ring. So the management is typically conservative, no surgery needed most of the time.
Okay, that distinction's helpful. Now, classification. I know there are a few systems. Why do we need to classify them? What's the point?
Classification is, well, it's like your map for the injury. It helps you figure out how it probably happened, the anatomical pattern, and really importantly, how stable the pelvis is. And that stability quotient directly impacts how we manage it, especially deciding about surgery, about fixation.
Makes sense. Okay, let's tackle the tile classification first.
Right, tile. It groups them into A, B, and C, based mainly on stability. Type A fractures are stable. The pelvic ring itself isn't fundamentally disrupted, so this includes those avulsion fractures we just talked about, maybe an isolated break in the pubic ramus, that bit at the front, or the iliac wing, the wings on the sides, basically single bone breaks that don't compromise the whole ring structure.
So type A is the relatively okay category, generally
You
speaking.
could say that, yeah. Then you move to type B. Now, these are rotationally unstable, but they are vertically stable.
Okay, what does that mean, rotationally unstable?
Think of the pelvis like a book. It can be forced open or squeezed shut, but the spine, the vertical structure, holds. So subtype B1 is the classic open book fracture. The front joint, the symphysis pubis, springs apart. B2 is lateral compression on one side, pushing it inwards. B3 involves compression forces too, but causing rotation. The key is the back part vertically is still connected.
I see. So the hinge is broken, but the book hasn't fallen apart completely.
Kind of, yeah. And then that brings us to type C. These are the most severe in this system. Type C means unstable in all directions, rotationally and vertically unstable. The pelvic ring is completely broken in at least two places.
Okay, so total disruption.
Total disruption. And because of that, these are far more likely to involve major bleeding, major instability. They need aggressive management, almost always surgery. That complete break means a much higher risk to those big blood vessels.
That really drives home the severity of type C. Okay, what about the Young-Burgess system? How does that differ?
Young-Burgess focuses more on the mechanism, the direction of the force that caused the injury. Type I is anterior-posterior compression, APC. Force from front to back. It widens the symphysis, but less than 2.5 centimeters.
Okay.
Type 2 APC is a stronger force, widening the symphysis more than 2.5 centimeters. And crucially, it often means the ligaments at the back, the sacrospinous and sacrotuberous, are torn. That posterior ligament damage makes it much more unstable than just the front opening up.
Right, those back ligaments are key supports.
Exactly. Then type 3 APSC is the worst of this type. You get complete disruption of the SI joint at the back on one side, often with vascular injury, plus usually compression injuries on the other side, and an open book at the front. Very unstable.
That sounds complex. Is there a simpler classification for, like, the immediate A&E situation?
Yes, absolutely. The World Society of Emergency Surgery WSCS classification is really practical for that initial assessment. It looks directly at hemodynamic status, blood pressure, circulation, and mechanical stability. Grade I, minor. Patient's blood pressure is fine, pelvis is mechanically stable. Grades 3 and 3 are moderate. Blood pressure is okay, but the pelvis is mechanically unstable based on tile or young Burgess.
Right.
And grade 4, severe. This is any pelvic fracture where the patient is hemodynamically unstable, their blood pressure is dangerously low, they're in shock. Doesn't matter what the x-ray looks like initially in terms of stability if they're unstable, it's grade 4.
That makes a lot of sense for prioritizing immediate actions.
Hmm.
Okay, let's shift gears slightly. How do these fractures actually happen, the etiology?
Broadly, you can think high energy versus low energy. High energy is your major trauma. Road traffic collisions, falls from a significant height, crush injuries. The force involved is huge, often leading to those unstable type B or C fractures.
And low energy.
Low energy is typically falls from standing height. You see this much more in the elderly population. And the big factor there is often underlying osteoporosis. The bones are just weaker, so even a relatively minor impact can cause a fracture. Often these are the more stable type A kind of fractures.
So who's most at risk then?
Well, obviously, activities with a high risk of trauma, certain sports, occupations. Osteoporosis, as we said, is a major one, particularly for older adults. Advanced age itself is a risk factor just due to natural bone density loss. And any condition that weakens bones, like certain cancers spreading to bone or metabolic bone diseases.
Okay, clear. We've got the definitions, causes, risks. What's actually happening biologically, the pathophysiology?
At its core, it's simple physics. Force applied exceeds bone strength, causing a break. But the consequences go beyond the bone. You get damage to the strong ligaments holding the pelvis together, muscles, and potentially adjacent organs. And the critical point, because the pelvis has such a rich blood supply, is the risk of bleeding. Significant life-threatening bleeding leading to hypovolemic shock. That internal hemorrhage can be the real killer, even if the fracture itself doesn't look initially devastating.
Yeah, that really underscores the urgency. So if someone comes in with pelvic pain, what else should be on our minds? The differentials.
Good question. You need to consider other things. A hip dislocation can present very similarly severe pain, inability to move the leg. Lumbar spine fractures can sometimes refer pain down into the pelvic area. And, of course, significant soft tissue injuries around the hip and pelvis, large hematomas, a severe muscle tear.
Right, need to keep those possibilities open. How common are pelvic fractures, and who gets them? Let's touch on the epidemiology.
Okay, so they account for roughly 5% of all fractures you'd see in trauma settings. They tend to be a bit more common in males, and the peak incidence is actually in young adults, likely linked to that higher rate of high-energy trauma. About a third are isolated pelvic fractures, but importantly, you find them in 10 to 20% of patients with severe multiple injuries. So finding a pelvic fracture often signals a higher overall trauma severity.
Are there patterns in terms of who gets which type?
Yes, definitely. Major trauma, as we expect, leads to the more significant unstable fractures, the B and C types. Interestingly, isolated pubic ramus fractures are actually quite common, but sometimes they get missed initially if you're not looking carefully. And those avulsion fractures, we see them most often in sporty teenagers. Hamstring pulling off the ischial tuberosity is a classic, a little mnemonic. Think sporty avial illusions in teens.
Okay, useful.
And then osteoporotic fractures, often those stable pubic rami or sacral fractures, they're much more common in people over 60, typically after a simple fall.
Got it. So let's talk presentation. How do these patients look when they come in? What are the clinical features?
Well, the general picture is often pelvic pain, sometimes severe. Difficulty walking or even standing is common. You might see obvious swelling, bruising around the pelvis, hips, perineum, maybe even a deformity, though not always. And critically, in severe fractures, you need to look for signs of shock tachycardia, hypotension, due to that internal bleeding.
Are there more specific things we should be looking for or feeling for?
Absolutely. On examination, you need to gently palpate. Check for tenderness over the pubic symphysis, along the iliac crests, over the hips, and importantly, over the sacrum at the back. Look closely for bruising, swelling. Sometimes you might feel crepitus, that sort of crunching feeling of bone ends rubbing. A useful mnemonic for local signs. TBSCs, terrible bruising, swelling, crepitus. If you find those, think pelvic fracture.
TBSC.
Other specific signs. Blood in the urine hematuria, bleeding from the rectum, On rectal exam, you might feel a hematoma or even a sharp fracture edge. The location of bruising can be a clue too. Above the inguinal ligament in the upper thigh or perineal bruising all point towards a pelvic injury.
Right.
And always check neurovascular status in the legs, sensation, movement, pulses. Pain or instability when you gently move the hip, especially adduction, bringing the leg inwards, might suggest the acetabulum, the hip socket, is involved.
And you mentioned gender-specific signs earlier.
Yes. In men, specifically look for signs of urethral injury. Remember the mnemonic hub? High riding or boggy prostate on rectal exam, urethral blood at the meatus, the opening, and scrotal hematoma. Finding any of those is a big red flag.
Pub-B. Got it. And for women?
In women, unexpected vaginal bleeding or feeling a fracture line during a gentle bimanual exam can indicate a pelvic fracture.
How might the presentation differ between a high-impact crash versus a low-impact fall in an older person?
Good point. High-impact fractures usually present more dramatically. Severe pain, often signs of shock setting in early, even if the full extent of bleeding isn't obvious yet. The pelvis is likely unstable, though a visible deformity isn't guaranteed. And a really key thing, even with unstable fractures, patients might still try to move or walk initially because of adrenaline or confusion. Don't let that fool you.
Right. Don't be falsely reassured.
Exactly. Low-impact fractures, say in an elderly patient after a fall, might be less dramatic, less hemodynamic challenge initially. They'll have pain on walking, but might still manage it, maybe unaided. And crucially, in these cases, strongly advise against doing that old springing the pelvis's maneuver to check stability. It's unreliable, painful, and can actually make things worse, potentially increasing bleeding.
Okay, very important point. So based on all these signs and suspicions, what investigations do we order?
Initial bloods and urine tests are key. Urinalysis for hematuria, a pregnancy test in women of childbearing age, and serial hemoglobin and hematocrit, checking their blood count repeatedly to see if it's dropping, which indicates ongoing bleeding.
And imaging.
Imaging starts with an AP X-ray of the pelvis. That's your first look. Often gives you the diagnosis and a basic idea of stability. But very often, you'll need a CT scan of the pelvis, usually with intravenous contrast. This gives much more detail on the fracture pattern, helps quantify bleeding, and checks for associated injuries to organs or vessels. Ultrasound, like a fast scan, can be useful initially, especially in unstable trauma patients, to quickly look for free fluid, suggesting bleeding, in the abdomen and pelvis. If you suspect a urethral injury, those hub signs in men, then a retrograde urethrography is needed. That's where they inject contrast dye into the urethra to visualize it on X-ray.
Okay.
For patients who are hemodynamically unstable and you've ruled out major bleeding elsewhere, like the chest or abdomen, then arteriography and angiogram might be done. This can pinpoint the bleeding pelvic vessels and allow for embolization, basically blocking them off.
And if there's blood in the urine, but the urethra seems okay.
Then you'd think about a bladder injury, and a cystography might be performed putting contrast into the bladder to check for leaks.
Right, a logical progression. So we've got the diagnosis. What are the overall principles of management?
Management really hinges on three things: the patient's hemodynamic stability, the degree of pelvic ring instability based on the classification, and any other injuries they have.
Let's start with the stable ones, the type A injuries.
Okay. For stable type A fractures, it's usually non-operative. The orthopedic team gets involved for pain management, good analgesia. There'll be a period of bed rest or limited weight bearing, followed by gradual mobilization. This often means using crutches or a walker, slowly increasing weight on the leg over weeks, maybe even months.
What about those avulsion fractures?
Usually rest and pain relief is enough, but for larger avulsions, like a big piece off the ischial tuberosity, surgery might be considered, especially in athletes, to reattach it and potentially improve long-term function. And don't forget DVT prophylaxis, blood clot prevention, especially if mobility is significantly reduced for a while.
Okay, now for the big ones, the unstable type B and type C fractures, what's the approach there?
This is where trauma protocols like ATLS really come into play. First rule, minimize movement. If you have to move the patient, use a straight lift or a scoop stretcher. Avoid rolling them if possible, as that can worsen displacement and bleeding. Resuscitation is key. Manage hypovolemia aggressively. Anticipate coagulopathy problems with blood clotting, especially with massive bleeding. Get blood products ready early. Sometimes a damage control approach with limited fluids initially is used.
And stabilizing the pelvis itself.
Yes, early stabilization is crucial. This often involves external fixation. That could be a formal external fixator frame applied in theater, or more immediately, a pelvic binder, or even just a tightly wrapped sheet around the pelvis at the level of the trochanters. The idea is to compress the pelvis, reduce the volume, help tamponade bleeding, stabilize clots, and limit further injury.
What other immediate things might be done?
Things like M-mask trousers, anti-shock garments, are sometimes used, though less common now.
Huh.
Selective arterial embolization, as we mentioned, is key if there's ongoing arterial bleeding identified on angiogram. If it's an open fracture, especially with perineal or bowel involvement, a diverting colostomy might be needed early on.
And that point about catheters.
Yes, crucial. Avoid trying to insert a urinary catheter if you suspect urethral injury, those H-B signs. You could cause more damage. A urology consult is needed, maybe for a suprapubic catheter initially. Sometimes a diagnostic peritoneal lavage, DPL, is done to check for abdominal bleeding, but it's usually done via a supraumbilical approach to avoid the pelvic hematoma.
And then definitive management.
Definitive management depends on the specifics. It could involve skeletal traction for a period, followed by internal fixation with plates and screws, or continued external fixation. The goal is stable fixation to allow for pain control, easier nursing, and earlier mobilization, which helps prevent complications like pneumonia and clots. It absolutely requires a multidisciplinary team: trauma surgeons, orthopedics, interventional radiology, critical care, nursing, everyone working together.
That's a really comprehensive overview of management. What about the outlook? What's the prognosis?
It's highly variable, depends hugely on the initial fracture severity and, critically, any associated injuries. For severe pelvic trauma overall, mortality rates are significant, maybe 8–15%. Often, death isn't just from the pelvic bleed, but from associated head, chest, or abdominal injuries.
And if they're unstable on arrival?
If they arrive hemodynamically unstable because of the pelvic fracture, the mortality jumps dramatically, can be over 40%. It's a marker of massive hemorrhage.
But stable fractures do okay?
Generally, yes. Stable fractures tend to heal well with conservative management, but those high-energy fractures, even if the patient survives, have risks. Bleeding, organ damage, infection, thrombosis, embolism. Severe open pelvic fractures also carry a very high mortality, again, potentially over 40%.
Does involving the hip socket change things?
Yes. Fractures extending into the acetabulum generally worsen the long-term functional outcome. More risk of arthritis later. Full recovery, especially after major fractures, often needs prolonged physiotherapy. And even then, some patients face long-term issues like chronic pain, stiffness, reduced mobility, sometimes sexual dysfunction. And any associated nerve injury is a strong negative predictor for long-term function, regardless of the bone healing.
Okay. Finally, could you just summarize the main potential complications we need to be aware of?
Sure. There's a definite increased risk of blood clots, DVT, and PE. Intrapelvic compartment syndrome is rare, but serious pressure building up inside the pelvis. Continued bleeding is always a worry. Damage to the genitourinary system, bladder, urethra, prostate, vagina. Associated injuries to chest or abdomen in major trauma. Long-term, as we said, chronic pain, impaired mobility, nerve damage issues, sexual dysfunction, post-traumatic arthritis. Infection is a risk, especially with open fractures or surgery, and damage to internal organs can lead to long-term disability or even death.
A really significant list. It certainly highlights why getting the initial assessment and management right is so critical. Well, this has been incredibly thorough. We've gone from the definition through all the classifications. Tile, Young Burgess, WSES, looked at etiology, risk factors, pathophysiology, differentials, epidemiology, the key clinical features, and those mnemonics.
TBSC and Hubble B.
Exactly. Then investigations, the detailed management for stable versus unstable types, prognosis, and finally, the complications. Hopefully that gives everyone listening a really solid, memorable framework for their MSRA revision on pelvic fractures.
Absolutely. And I think the key take-home message, considering the potential morbidity and mortality, especially with severe fractures, is that early recognition and appropriate, often multidisciplinary management is just paramount. That's true for the exam, of course, but even more so in clinical practice.
Well said. For more resources and practice questions to really nail your MSRA, do check out passmsra.com and also freemsra.com. Thanks for joining us for this deep dive today.